Hello, good morning, everybody, and welcome to this Health Foundation webinar, all about levelling up health. We've got a good exam question this morning, and the exam question is, what can local government do to level up health, and how can national government help the most? Why is all this important? Well, I think we all know, all of those who've dialed in this morning, we all know about health inequalities and stalling life expectancy and the impact of the pandemic on health. So there's the nation's health fabric to be mended, inequalities to be addressed, and now there's a moment to act. We also know that there's an important link between health and wealth. Poor health means poor prosperity. We also know that improving the factors that affect our health, housing, education, early years, environment, air quality, are heavily influenced by local government, more than national government probably. And we also know that levelling up is the central thrust of the Prime Minister's agenda for the government, and there's a lot of funding attached to it in what is actually a very resource-constrained environment, lest we forget. So while the white paper on levelling up is being worked up now, there's still a chance to influence it, even though we don't know at the moment whether health will be woven into that to the extent to which we'd like. So to help us on thinking about the role of government in levelling up health, I'm really pleased to introduce, we've got 3 expert speakers this morning. So I'm just going to briefly introduce them. We've got Dr. Jo Bibby, who will speak first. She's the Director of Health here at the Health Foundation. Then we have Greg Fell, who is the Director of Public Health in Sheffield, where he's been since 2016. And many of you will know him as his Twitter persona, Felly500. Greg, I don't know the meaning of the 500, so perhaps you can tell us later. And then we also have Joanna Killian, who is Chief Executive of Surrey County Council, where she has been in that post since 2018. So their full biogs of these wonderful experts are available on our website, so you can have more detail. So what we're going to do today is to kick off with Jo doing a short presentation, then we'll have Greg and Joanna who will give some opening responses, and then we'll have a fuller discussion, and we're going to aim to finish at 12:45 on the dot. And just some other quick bits before we start. The event is being recorded, so it'll be on our website within the next 24 hours. So do tell your friends who missed it or look again. And then we'll also be taking questions, of course, from you. So please use the Q&A box to ask your question. And if you see someone else that's asked a question that you really like, then you can upvote it so it gets to our attention more quickly by clicking the thumbs up icon on the relevant question. And thank you to those who've already submitted some questions. I've got all these here so I can refer to them. And then if you'd like to tweet, please use hashtag THF levelling up health, hashtag THF levelling up health. Okay, so right, let's get started. I'm going to hand over now to Jo, who's going to do a short presentation. Thanks, Jo.
Great, well, thank you, Jennifer. I'm going to start by sharing my screen just to get some slides up. So I'll give that a moment just to come through. Hopefully people can see that now. So just to set a bit of context for this conversation, I'm just going to run through a few sort of questions. And the first one is, why does the government need to be thinking about levelling up health in the context of its levelling up agenda? And I think there's sort of 2 sides to this. One is there is a kind of political imperative. And if we cast our minds back to December 2019, when this government was elected, people will remember there was a dramatic shift in the sort of political landscape of England. And we did some analysis after that, looking at the healthy life expectancy of the sort of traditional Conservative seats, so the dark blue bar here, the ones that were held in 2019, and we compared that with the seats that were won by the Conservatives from Labour in the 2019 election. And what you can see is, whereas traditionally the Conservatives held seats where healthy life expectancy was above the England average, in the election in 2019, it took on a huge new swathe of seats where healthy life expectancy is well below the England average, and in fact is now below the seats held by Labour. So health really is something that sits on this government's agenda. The second thing is, as Jennifer said, health and wealth are inextricably linked. We've known for decades, if not centuries, that economic conditions are a key factor in shaping a healthy population. And we've seen over the last 18 months how health can really be sort of jeopardy to our economic context as well. But it's not just in a pandemic when people's health affects their the economy. We've done analysis where we've looked at employment patterns for people, depending on whether or not they have a work limiting condition. And what we see is people who have a health condition that limits their ability to work, employment rates are at 47% compared to 81% for people without underlying conditions. And the pattern of this poor underlying health varies geographically, as you can see from the chart on the slide. And in fact, there's 15% of council areas in Britain where over a fifth of the working age population has a work limiting condition. And I think this is really important to bear in mind, because this is something that will act as a brake on recovery. If people aren't well enough to work, it will reduce the ability with which the government can pursue its levelling up agenda. And there's a wider discourse I think we're all starting to be familiar with, where people are saying we need to look beyond GDP as a success measure. And perhaps sort of, the most notable example of a country that is trying to look beyond GDP is New Zealand, with their 4 capitals approach of natural capital, human capital, social capital, and financial capital as being areas against which they're measuring success. But we also have an opportunity to start thinking about this differently in the UK. Last year, the ONS published their health index, which is starting to look at how we can bring together indicators and measures of factors that shape people's conditions for a healthy life, looking at them in 3 categories: healthy people, healthy lives, and healthy places. And these indicators are used to produce both a national index for health, but can be broken down to regional and upper tier local authorities and shortly lower tier local authorities. So we do now have ways of thinking about a broader set of success measures for levelling up. The next thing I wanted to consider is what is the size of the challenge. So we've seen some of the variation in life expectancy by geography, but just to remind people of the differences that we see on the back of deprivation. So this is the latest ONS data, and there's a 7.7 year difference in life expectancy for women between those living in the 10% poorest or the 10% richest parts of the country, and a 20-year difference in healthy life expectancy, which actually has increased slightly since the last calculations. So I wanted to then think about this in a sort of different context. Another phrase we hear a lot about at the moment is global Britain. So I thought, well, how does life expectancy in the UK compare with other countries? So this is World Health Organization data ranking countries by their average life expectancy. So just scrolling through to see where the UK is. Here we have the UK with the average life expectancy of 81.4. Which is 25th in the sort of global rankings. Now, if we then ask, well, what does this mean for different people in the UK? If you're in the top decile, the richest segment of the population, your life expectancy is 84.8 years. This is based on England data. So somebody in the top 10% by deprivation can expect to have a life expectancy not a little bit more than the average life expectancy in Japan. But looking down into where the people with living in the poorest 10% of England, life expectancy is 76.5 years, which is comparable to Antigua and Barbuda. And to put that in another context, the World Bank estimates the GDP per capita for Antigua and Barbuda is $9,000 compared to $40,000 per capita for the UK. So I think this really speaks to the fact we need to be looking beyond economic measures for success. So why is local government critical to success? And as Jennifer was saying, local government has a role in so many of the factors that influence our health. And people who know our work are probably familiar with this visual that sits with a suite of infographics that explore how different determinants shape people's health. And just as life expectancy and healthy life expectancy varies across the country, so too do the determinants of health and how people experience them. So we have an evidence hub that has a lot of analysis on different determinants and kind of give a flavour of the variation that we see when it comes to the quality of work. In the rural northeast, 43% of people report experiencing poor quality work, compared to 29% in the rural southwest. Thinking about young people in education, training or employment, that varies from 22% of young people not in education, employment or training in Doncaster, for instance, compared with 9% in Maidstone. We look at fast food outlets and density of fast food outlets in Camden. There are 174 fast food outlets per 100,000 population, compared with 36 in Wokingham. And, I could go on. There are significant variations in how we experience these determinants of health, depending on where we live. So what needs to be in the white paper if the government really is going to get to grips with levelling up health? Later this week, we're going to be publishing our 5 tests for the levelling up white paper. And just to cover these in brief, and I'm sure this is some of the stuff we'll get into discussion in shortly, our 5 tests are, first of all, is improving health and health equity an explicit measure of success? Second, are local and regional governments empowered and enabled to take action? Third, is funding directed towards the place that need it most? Fourth, is improving health and health equity an explicit consideration of all the investment and spending decisions? And then finally, is the visible action to support people with poor health get back into the workforce now? So with that, I will hand back to Jennifer and stop sharing.
Thank you so much, Jo. Just one very quick question. Levelling up, everybody wants to get into the levelling up white paper. If health isn't there sufficiently in the levelling up white paper, where else could national government act to, how else could it act other than loading it into levelling up as a policy?
I think levelling up is obviously a policy that's being directed at particular parts of the country. And so that on its own isn't going to be enough, because poor health doesn't just exist in particular geographies. Even within local authorities, we know there's significant variation in life expectancy and healthy life expectancy. So it's something that actually is relevant to the whole country, not just the levelling up agenda. And so other work that the Health Foundation we're doing at the moment is asking the question of how could you have a whole government approach to improving health and health equity, and what are the mechanisms you need to have in place to make that a reality?
That's lovely, thank you very much. Good. So let's move on then to Greg, who's going to respond to some of what Jo has said. Greg.
Thanks, Jennifer. So first challenge, you asked me why Felly, not Felly 500. There's already an @Felly. Sadly, they beat me to it. So she beat me to it. So 500 was the first number that sprang into my mind. I hope there aren't 499 other Fellys. I pity us all if there are. Anyway, so a quick thoughts on by way of response. Firstly, and I won't dwell on this, the central challenge is health trends. All of the health trends pre-pandemic are still there and have been exacerbated by the pandemic. Life expectancy and healthy life expectancy, historical progress is now flatlining, has been for quite a while now, actually. That's a national emergency. There's no two ways about that. There's no sugarcoating that. That is a national emergency, as important as all the other national emergencies. I'm personally not so worried about the pandemic related fall in life expectancy, because that's a temporary thing to do with a large number of excess deaths. So I would be worried if it was me, but the long-term trend is much more worrying. So the gap is still there. arguably beginning to get worse. The gap between the haves and the haven't. We talk a lot about geography, the affluent versus the deprived, but let's not forget this also plays out in ethnicity, disability, those with mental illness versus those without. So for me, the gap is 25 years. A man born in Dor tomorrow, the most affluent part of Sheffield, can expect to live a seventh of his longer life in a state of good health, versus a man born in Darnall can expect to live a third of his life in poor health, shorter lives in poor health. Some shifts in morbidity and mortality profile over recent years. The Lancet Commission has quite helpfully summarised a lot of that, so I won't dwell on it too much. The big deal is the shift from unimorbidity to multimorbidity, more common in working age people than the elderly. We all think multimorbidity is a thing of old people. No, it's more common in working age people. The Scottish study Karen Barnett did nearly a decade ago told us that. We've done the same in lots of towns now. They all draw the same broad conclusions. And the age of onset differs. Much younger age of onset to multimorbidity in the most deprived parts of town. Compare the age of onset of multimorbidity to retirement age, and you can quickly see why health isn't just a health and social care service issue. It's also an economic issue, to which I'll come back to. All of those things are unequally distributed. Most of those health problems are largely non-communicable diseases. So cancer, heart disease, respiratory disease, etc., most of which is largely preventable. We know what to do. The science is crystal clear. We can choose to or choose not to prevent them. For 30 years in my career in public health, we've been arguing for the thing that we currently call the left shift. For 30 years, we've done precisely the opposite of that. I'll let that thought hang for just a minute. So why health matters? Clearly, it's a matter for health and social care demand. Clearly, the gap between the haves and the haven'ts is a social justice issue. It's also a drag on economic productivity for the nation, for UK PLC. I'm told that there was a piece of work done by the Scottish government which looked at the constraints to economic growth. Top three in order: skills, obviously, lack of health, and carer responsibility, often secondary to health problems. So yes, of course, we talk about health in the context of health and social care demand, but we should also talk about it in the context of the economy. Where do we go on it? Framing, firstly, it's not a health is not a health service problem. It's a health problem. The clue is in the title. And as Joe has eruditely said, everything's in: housing, employment, transport, cigarettes, fat, booze, however you want to call, all of those things contribute to how healthy we are, not just the work that the NHS and social care system does, and Joe's talked us through that already. We've been in a pandemic, don't you know? Who doesn't know that? Probably, hopefully, the defining event of our lifetimes. Hopefully it will come to an end, and we'll get on to recovery. So some thoughts there. A growth-led recovery versus a health-led recovery. In previous significant economic shocks, we've had a economic growth-led recovery, which concentrated inequality and concentrated power. Imagine if we had a health-led recovery, and if we treated health as a national infrastructure project, a bit like HS2, and thought on it with similar timeframes. That would be an interesting thing to do. But an interesting thing to do. Something about reframing the value of good health to the whole of society and all things that sail within society. We definitely and rightly put a lot of energy into the NHS elective backlog. It would matter to me if it was me waiting 18 months for my hip replacement. We should also do the same for the social backlog. What did the pandemic teach us? Outsourcing can deliver scale very, very, very quickly, but not nuance. And not investment in outcomes and deep-seated investiture in our places and what matters to our communities. So, outsourcing did some good things, but we also need places. Places add a lot, and one of the critical learnings from the pandemic was about that. Responses to big structural things can't be done without central government, but it can't only be central government. Local and central both have to be in the mix here. We definitely can't do levelling up, in my humble opinion, from Whitehall. Needs some place-based shaping, and I'll come back on to that. Structural issues in society massively outgun individual behaviour and personal responsibility. We saw this. We now call it enduring transmission in some of our poorest communities. It's not to do with not following the rules and bad behaviour. It's to do with the type and nature of work, face-to-face or not. I cannot work face-to-face. 0 hours contract, pay, poverty, the ability to afford 14-day isolation. All of those are structural things. And if we want to solve some of the structural health problems, we have to look at structural things. So our health problems will not be solved by more or better healthcare services. That said, it would help. The central challenge is multimorbidity. Primary care is fundamentally important to addressing multimorbidity, and we all know where primary care is in terms of demand pressures at the moment, and we probably need to think hard on that. Also need to think hard on the inequality within primary care and how the resources distributed within the envelope of primary care too. The left shift I've talked about already. I'm still waiting for it. Wanless told us about it 20 years ago. We ignored him then. We can't exhume him from the grave, but we've wanted the left shift, but we have done the opposite. Health inequalities, or disparities as we now call it, will keep asking me, what should we do? Implement Mike Marmot's report, or Mike Marmot's 10-year on, or Mike Marmot's recent report in Greater Manchester. Can't rewrite it any more eloquently than Professor Sir Michael put it. And to be fair, we've implemented lots of those over the years. Some of them have had great traction, some of them haven't for all sorts of reasons. But I wouldn't stop just at Marmot. I'd get into the space where Eton and IFS is on economic inequality. I'd get into the living standards debate. And the stuff that the Resi Foundation, etc., are writing on at the moment. All of those things matter on health inequalities. Lastly, local government and levelling up. I hope I don't need to remind this audience about the level of financial risk in the local government sector. It's eye-watering, genuinely eye-watering, and most local authority directors of finance that I know worry deeply about the future. The IFS in 2019 published a report on kind of long-term trends in local government expenditure. That has consequence. There was a paper in Lancet Public Health 3 months ago that documented the link between long-term expenditure in local government and life expectancy. The science was pretty good, actually. There's always caveats with it, but we shouldn't underestimate the level of risk within local government at the moment, and that has bearing on levelling up. Lastly, what does levelling up mean? I'm not sure. A sort of a disputed and contested title. Does it mean redistribution? Do we want to go there? Clearly, that takes us into a space of naked politics. Worth a read of the IFS report of last week on the attitudes to inequality. It was a fascinating set of insights there. It's worth a read of. It's definitely worth a read of that. Does it mean hold the top steady and pull the bottom up? And we probably need to work our way through what that means in policy terms and probably political terms as well, which is above my pay grade. We can't do this only local. Devolution policy, Jess tweeted this morning, that devolution policy has only required reform at local level. We need reform at local and national level to really nail what levelling up means and make good on the Prime Minister's aspiration. There's no red button answer. There's no single big idea. I think the big idea is that there isn't a single big idea. One of the concerns I think many of us have is the time and energy we spend stitching together lots of disparate sources of funding into a coherent whole. And that will be a problem. But we need to treat levelling up as both a political and a managerial project. There's some hearts and minds and skills and competencies. And for me, the critical question on health and levelling up is who's responsible for the 25-year gap in healthy life expectancy in my town? Most people then look at the floor, and then some of them stare at me and say, you need to sort that, Greg. Easy, but actually nobody's responsible for it. That's a critical problem. Last point, there is now no longer an MHCLG. So the challenge of the new department is to embed the agenda across the totality of government. Easy to say, hard to do, as we all know, but that's, I think, one of the key challenges. Second challenge is it can't only be done from Whitehall. And the third challenge is, for me, and Joe's picked up on this, is the fundamental rules by which the economy works. We all want a well-being economy, whatever we call that and define that, and we all want that to address some of the inequity, both economic, health, and other. Let's not kid ourselves that the way the economy works is largely based on capitalism, and capitalism was built, my ex-boss told me this, has been built up over 1,000 years and has immense power and wealth behind it, and that will not be given up easy. So let's not kid ourselves about the difficulty of the challenge ahead. I shall pause for breath there.
Wonderful tour de force. Thank you, Greg. Just a quick one for you. We'll get back to this. You did say quite rightly there is no one silver bullet. But presumably there is one thing that would help, which is a strategy, at least to try to make inroads on some of the health issues that we've seen to address inequalities and improve health. Just saying that this government wants to have a strategy and tries and develops it. What do you think would be some short-term, easy to reach wins that it could show progress on in the short term? Either, you know, that would at least show some progress, because you can see governments of all hue, local and national, saying this is like boiling the ocean. You know, this is just too difficult. So, from your public health perspective, what are the sort of proximal things that could show some progress and give hope to those who really want to maintain a strategy?
Two things. One is the sort of the cultural shift of government. I think local government in this space, but the cultural shift of government that health isn't something that will be solved by the Department of Health and Social Care. Clearly that has a lot to add to the party, but it's not only the Department of Health and Social Care that has kind of the responsibility for the health of the nation. Second one, I'd probably start with the things that are very, very, very directly related to the burden of non-communicable disease, and accelerate our progress there. Tobacco is the new tobacco. Contrary to popular belief, tobacco is the new tobacco, and still responsible for 20% of all deaths and about 15% of all illness, there or thereabouts. The story on tobacco is a good one. Tobacco smoking prevalence has been coming down for decades. That hasn't happened by magic. It's happened because a lot of people have worked really hard on that. Let's accelerate some of the trends in the risk factors for those non-communicable diseases. Fairly non-controversial. We know what to do. It's not really a science question. It's an implementation policy question. So if I could pick two things, then it would be those two. But clearly there'd be a million and one other things I might say too. But I'll start there.
That's great. Thank you very much, Greg. Right, now we can ask Joanna from her local government perspective. Given a lot of agency, it seems, is in local government, despite the cuts we've heard about from Greg. Joanna, your comments would be really valuable now.
I mean, I should start by saying, I mean, maybe people listening to this would be curious about why the Chief Exec of Surrey would be invited to comment. People may have a perception of us as being incredibly prosperous, wealthy place, and may be absent of any need to discuss levelling up. And I would argue that this can't be a debate about London and the southeast versus the north. I mean, across my area, there is significant difference in life expectancy and in healthy life expectancy as well. So there is an absolutely live and active debate with our residents, with our councillors, about what levelling up means for us. And for sure, we want to be part of this conversation because we have communities that suffer multiple deprivation, including extremes of health inequality, partly driven by the affordability of housing. You know, when you live in a place when the sort of average house price is now sort of stretching on to £800,000, you know, many of our communities are working poor communities that suffer disadvantage. So I know the government is spending time thinking about what it means by levelling up, but for us in some places, it's sort of an urgent debate without, you know, whilst recognising there are many other parts of the country where it's a compounded, you know, multi-generational issue too. I would argue that local government is incredibly well placed to be able to respond to this, I think, in two dimensions. One, I think many of us know our communities and our places extraordinarily well, and have been working with partners to think about the organising principles between health, social care, our housing partners, police, others, to be able to mobilise, to be able to respond to new health legislation that is coming, but to put us into a good position so that we understand our communities very well, can address their health and care needs, but also tackle the other things that drive health inequality as well. But I'm also anxious that we don't fall into the trap of just having a sort of place-based discussion. We're good at this. But for me, some of the acute disadvantage and health inequality I see are within cohorts who are sometimes not welcomed in communities. So in another part of my life, I'm chair of St Mungo's. It's a homeless organisation. Many of the people that we support have multiple disadvantage, find it difficult actually to find access to the services and support. But in a sense, they need an approach that supports their levelling up as individuals with much more sort of connected and coordinated policies locally and nationally that can sort of change their lives as well. For me, this is about a mindset change. So if we're going to deliver a sort of levelling up agenda that must include improving health inequalities, I think as local government with our partners, we need to put sort of health improvement into everything that we do. So this isn't just, I don't think, a conversation between public health professionals, adult social care professionals, housing professionals. This is about weaving into everything we do a sense that by implementing this strategy or this action, it can improve health and well-being. So that can be anything to how we, I think, tackle big climate change issues as it comes towards us, rethinking how we deliver sustainable transport, rethinking how we're going to be able to deliver sort of high quality housing going forward. So it's how we thread that through and deliver to the principles that are set out by Marmot. I think we've got to seize the opportunity of the changes that are coming and the reforms. As our new integrated care partnerships find roots, it must be the case that local government is pushing the need for the new strategic direction to be clear about the importance of addressing population health and tackling health inequalities. And we do it with teeth. And while there are backlogs to address, concerns about future waves, we've got to turn our attention in these new settings to thinking about tackling inequality. And for me, if levelling up is going to actually take hold and give effect to change, we've got to think about not only the sort of accountabilities that secretaries of state might have and the duties that they should have to coordinate themselves to deliver levelling up and better health outcomes. I think we really have to challenge ourselves locally about what is the accountability model so that local people understand that as we tackle health inequality, they know who to point to. And, you know, that is there maybe in developing mayoral models elsewhere, but in some parts of the country, that accountability, I think, needs to be stronger and just can't sit with health colleagues. I guess my last point, and colleagues have already mentioned it, I mean, local government has suffered significantly, hasn't it, in terms of the cuts it's had over the last few years, the 23% real terms cut in public health funding, for example. And while we've welcomed the new settlement for health and social care, some of that cash will take a time to get into the care system. Local government will, I think, will have a difficult time through the CSR. So I think there's a realism about what is the model that we need to be able to invest in care and support. How do we work with our sort of business communities? You know, how do we act as an anchor institution? Many places we're the biggest employer. How do we sort of work those relationships to make sure that, you know, every penny that we have can support both levelling up, but the sort of health dimensions of that for sure.
Thank you so much, Joanna. Can I just sneak in a question? We've got some fabulous questions from listeners, so I'll come to those in a minute, but just this one for you. Leaving aside national government, just thinking now about local government, what's in your powers to do? What's your sense of the extent to which local authorities up and down the land have a decent health inequality strategy, something to improve health and reduce inequalities? And what's the state of what you call in local government sector-led improvement in this area to learn from the best?
Yeah, I think there's some sort of outstanding examples of plans to tackle health inequalities. I think, you know, the best councils and their partners have really stood back post-COVID and worked hard with their communities to get their communities to say what is it that they want, you know, what are the issues that they have faced. And for sure, you know, mental health, for example, has come out as a real issue, and unless we can sort of address that, it's proper. So I think some places have got really good plans, others I think recognise they really have to sort of address this now. I think it's also true that some of the partnerships focus is and will be on, I think, sort of tactical stuff to meet NHS delivery requirements, and that's always tricky, and sort of limited, I think, capacity for sort of self-improvement here too.
So there could be some room for development there that could happen, even if it's peer development, absent any national action.
Yeah,
great stuff. Thank you so much. That's a great platform. Let's come to some of our really interesting questions here. So the first one is quite profound, which is what is the best measure of health, and are we really focusing on life expectancy or healthy life expectancy? Should there be other measures that are better? So who'd like to have a go at that one? Greg.
Cheers. So obvious answers to the question is healthy life expectancy, not life expectancy, because the healthy life expectancy takes into account the health state as well as the how long you can be expected to live. There's all sorts of statistical jiggery-pokery and wizardry in the how one derives the healthy bit of healthy life expectancy, but bluntly, I don't think anyone can think of a better measure than healthy life expectancy. Yes, there are other indicators. One might have sort of indicators of the sort of mortality, morbidity from the big illnesses, but that kind of medicalizes what essentially is a social problem. There will be indicators around the robustness and fitness of the housing stock or poverty within certain cohorts, all of which reflect the determinants of health. But from a health perspective, they all culminate together in healthy life expectancy. Its problem is it's a vast, broad concept, and people want specific, tractable stuff. And I don't quite know the right answer there.
Thank you. Joe, do you have any comments, given that you were advising the ONS on the Wellbeing Index?
Yeah, I mean, certainly agree with Greg. Healthy life expectancy seems a sort of overall global measure. I think one of the challenges with it, and whether or not we'll see change in it, or the change that we want to see, i.e. improvement, is that we face that problem that, in a sense, a lot of poor health and future poor health is already baked into the system, as it were. So, you know, Greg talked about smoking, we've talked about poverty, all these things that we know are detrimental to health, and they're out there and they are going to be feeding through. So there is a difficulty that we face with healthy life expectancy that in some respects, you know, some of that poor health is going to carry on regardless of what gets changed today, because we baked it in. But that's where I think the ONS Health Index can help, because what they've tried to do in the ONS Health Index is break it down into a smaller set of metrics that they know there is good evidence that by changing some of those metrics, you will actually start to make some difference to health. So, sometimes potentially quite quickly, but equally potentially in the longer term. So to give an example of some of the things that are in there, they include things like employment, working conditions, they include things around service availability, they include things around access to green space, access to affordable housing and so on. So I think using, having a goal in mind is important, but probably also having to track against a basket of measures that are more amenable to immediate change, even if the impact on health will take time to feed through.
Thank you. And just while we're on this measurement issue, there's been a few questions about mental health, and Joanna mentioned this. You know, does life expectancy or healthy life expectancy, in a sense, privilege physical disease and not psychological or psychiatric ill health? Do we need to focus more on mental health than we do? So, thank you, Greg.
Yeah, well, everyone was staring at it. It was like the OK gunfight at the OK Corral. So yes, yes, we do need to prioritise mental health more. You know, no two ways about that. As in physical health, term used advisedly, that isn't a problem that will be solved by more or better treatment services for people with a mental illness. It's a sort of a much more holistic thing. But in short, answer to the question is life expectancy is doesn't have that much of a bearing to mental health, other than suicide, which is often a very young age, and that has a big impact in terms of lives lost. Years of life lost, but fortunately relatively rare. But big impact, high consequence event, obviously for individuals and families concerned. Healthy life expectancy, yes, does take into account mental health. Again, I'd need to look at the epi books for the statistical wizardry and jiggery pokery as to exactly how, but in short, yes, mental health, and I do mean health, is taken into account within the calculus on healthy life expectancy.
Thank you very much. And of course, depression is the biggest single factor, isn't it, that's associated with multiple chronic disease, and also mental ill health in youth is very much a harbinger of physical ill health later. So Joanna, you had your hand up.
No, I mean, I was going to raise that point, particularly in relation to children. And, you know, I've been genuinely horrified, actually, by the number of instances of self-harm, the difficulty we've had about young people being able to access appropriate care, the level of preventative support. So in our place, we've been running a sort of mental health reform programme across partners, led by local government, actually, with business involvement, because it was so profoundly awful to see through the pandemic the instances of self-harm, child suicide. I mean, just terrible. And I think a wake-up call for all of us in our system to say, actually, we've really got to think about how we reprioritise investment across our system to tackle what we think is such a stark problem in mental health. And you know, there are so many people living with chronic multiple conditions, and on top of that, they have, as you say, problems with sort of depression, and that sort of, you know, filters out into households and makes caring more difficult. And yeah, it's a thing we've got to solve, isn't it, for sure?
Yeah, indeed. Thank you. So let's move on to some other sort of batch of questions. There's a few questions about the new OHID, the Office for Health Inequalities and Disparities. Or is it Health Improvement and Disparities? Probably, sorry, that's probably what it is. So the questions relate to what should be the key priorities of them, and I'll sneak in an addition, and how should OHID work with local government to achieve those priorities? So, Greg, let me go to you.
This is like the hardest job interview in the world. In reverse order, the working with local government, I think the way in which governments are, Whitehall are increasingly working with local government now in terms of can't only be done centrally, have to work in partnership with local. You know, on COVID, actually, a lot of that's worked out quite well. So cement some of that in, but obviously apply it on a much bigger and broader scale. On OHID itself, in terms of key priorities, my top two priorities would be one, the accountability framework, being very clear with the machinery of government, both political and civil service, on the question of who is accountable for healthy life expectancy, reflecting there's no single answer to improving it, but who's accountable for it and how? And secondly, the approach, which maybe take but the approach of improving health will not be adequately solved by personal responsibility. It's necessary, but nowhere near sufficient. And all of the evidence in all of the health areas I know say structural interventions way outgun personal individual level interventions. So those would be my two key. They're both structural cultural issues as opposed to specific topics. I don't think there's a single specific topic that would be top of my list. I've nailed the structural and cultural stuff first.
Thank you. Jo?
Yeah, thank you. I mean, I think I'd echo what Greg's saying, that, I mean, there's clearly going to be things that the Office for Health Improvement and Disparities will need to work on that kind of classic public health agenda. But I think if we're really going to see that shift in outcomes, it's about how do we mobilise the whole of government to really think through the way in which the policies that they enact can start to help improve health in local places. And I think one of the things that, we have the evidence, we know the things that work, we've had plenty of things that work in the past, possibly fall out of favour, maybe some will come back in. I think it's probably less about some of the what policies do we need, but a lot more thought about how government works together. Right. And I think we need to be learning from where we have seen successful cross-government working on things like the climate agenda or mental health strategies, to really think what can we learn from that. And we're going to be shortly publishing a sort of document setting out how we think government needs to work together. So we know things like strong political buy-in are important. We know there needs to be binding targets to hold departments to account. But we also have to look at things like how spending decisions are made by Treasury. What gets factored in when then looking at the return on investment? Over what time frame are we looking for that return? As Greg was saying at the beginning, we need to think about the challenge of improving healthy life expectancy akin to something like HS2. It's a long-term programme of work that's needed, and we need to be able to demonstrate the value of spending things now, even if they may not show the benefit for 20 or 30 years' time, as we've seen with the recent evaluation of Sure Start.
Thank you.
I think for the office, it's how do they get that genuine cross-government working in place?
Yeah, so again, a sort of structural generic thing rather than a specific disease or health area. Thank you. Joanna, did you have anything in comment there?
I mean, I agree with those comments, and just, I think it would be desperately sad if stuff that is working so well at a local level was sort of sucked up into a new sort of central organisation. So we've got to keep local what is working incredibly well, give it sort of duration, and for government not to think that a snatchback is the answer. I think that would be desperately sad.
Thank you. Okay, there's a few questions about local government, and I guess that they can be boiled down to this question. Apart from money, from wanting more money, what does local government need from national government in order to pursue this agenda? What's the hot thing that you would, if you were writing this white paper on levelling up, perhaps, what would you want to put in there that would really give a boost to local government? Greg?
So three things: money, but we can't have that. So secondly, not heavy duty command and control. These are complex, difficult challenges that I don't know what to do there, and I don't think they can be solved by command and control. And thirdly is there's some cognizance of the sheer time and energy to stitch together all sorts of different pots of funding that come from this department or that department into a coherent whole. That requires a huge amount of kind of managerial and sometimes political capital, and a different way of addressing that problem.
Yeah, thank you. Joanna? With Michael going in your patch, maybe you are holding the pen.
Sadly not. I mean, I think there's a few things. I mean, I don't think we'll get more money, but it would be great to think that actually we had more predictable sort of funding, and that would allow us to sort of build programs that had sort of longevity in them. I think there are existing sort of pots of money that the government have targeted. You know, the Levelling Up Fund that was created in 2020, it's got had nearly 5 billion quid's worth of money in it, but it's not due to be allocated, I think, on current terms around multiple declaration, but, you know, on the basis of need for transport connectivity or need for growth. And somehow we've got to make sure that existing pots of money, if they survive the CSR, actually have a sort of wider definition. I mean, it sounds really sort of tedious at one level, but I think there's a range of legislation that needs to sort of be reformed so that we could all have a better articulation and understanding about what inequality means and deprivation means, to enable us to act as we could. And people have mentioned, I think, the sort of the importance of having this as a cross-departmental agenda, so that, you know, we're not having to go up and down different silos to have different conversations with different departments to get the same outcomes, really. And I think through all of this, it is just making sure, as big policy is made, there's always you know, the voice of individual people, residents and communities. So it would be great if some of the policy making, you know, the policymakers could hear what local people felt about what they need to have, you know, their health outcomes improved.
Thank you. And that leads me on to another clutch of questions, which can be loosely called about social capital locally. So we talk about national government, we talk about local government, but of course there's a strong role for communities, community groups, voluntary groups. I know we've got Bren watching. Hello, Bren. So how does local government liberate and work very productively with local communities that have really, as we've seen in the pandemic, come to the fore and really help communities in a way that local government can't reach? Joanna, as you've got the floor, can I ask you first? So social capital and prioritising that and the value of local people. Yeah.
I mean, for me, this is where sometimes, you know, local government needs to get out of the way as well, and sort of recognise that there is so much sort of capacity and capability in our communities, and sometimes we are, you know, a hindrance to that. You know, for me, given the sort of paucity of funding there might be, you know, we've just got to think about sort of different incentive models that makes it possible for people in sort of community and voluntary services to sort of participate in sort of old language, I know, commissioning stuff that will still need to go forward. And I think, you know, part of my view about sort of reforming legislation for this is, you know, many councils spend quite a lot of time thinking about how they can put sort of social value into all their procurement activity, but it feels quite tokenistic at times. So again, how can we be much more sort of empowered and bold to think about genuinely how do we get value from all of that activity that can sort of draw in the capacity of our communities? For me as well, I think some of the sort of intractable problems that we've got, you know, I see groups of groups of sort of innovators with sort of good money around them, sort of coming up with some really good solutions. And sometimes I think the sort of bureaucracy of local government inhibits sort of innovation as well. So what are the sort of incentives that we can use to drive that? I think my challenge a bit into the sort of community voluntary sector, you know, who would talk about the value they have as social capital, is there are so many organisations in this space, and, you know, how do we encourage organisations to come together? There's a lot of dissipated capital everywhere, and I think there is a need for a bit of agglomeration in this space, as well as being sort of hyper local.
Just while you're there, Joanna, I mean, obviously there's an issue, you know, as someone said in the chat, you know, national government has to trust local government. Yeah. But also, doesn't local government have to trust some of the community groups to do the right thing? And just one small thing, I saw this eye-watering project recently, which was this lovely the dance group for young people in Camborne that was set up, which single-handed by a local police retired police officer and friends. And this really helped teenagers go off the streets. You know, drinking went down, A&E visits went down.
Yeah.
And it cost something like 20,000 a year. It was just really tiny. The local authority was asking for very, very specific outcome measures and so on, which are actually quite hard. So it's that trust, isn't it? It's how do we get trust in a very resource constrained environment, when of course you want to see value for money, but how do you do it without strangling the local group?
Which is why I think we just do need a different view about sort of like commissioning for outcomes. And I have worried that, you know, we've made the articulation of outcomes and all the measures so complex, as you say. And I suppose with my St Mungo's hat on, I sort of see it from the other way round, and it's really time consuming and expensive, isn't it, for organisations to have to do all this stuff when intuitively you know, they know. And I think we've got to lighten up a bit on this, and the trust thing is really important. Important.
Indeed. Greg and Joe, Greg.
So quickly, so variations on a theme. I agree with Joanna completely. There's on commissioning for outcomes. What outcomes? And I can't define them, and I'm quite clever in these matters. And there is something about the more we say the word commissioning for outcomes, the more we build up a set of infrastructure to enable us to measure and monitor that. And we don't know. So I increasingly I'm thinking of abandoning use of the term, to be honest. Something about also long-term versus short-term investment. You know, we all know that we have contracts that are 3 months long, and we make people sweat within an inch of their life for £4.50, which isn't the same as local authority employees have to deal with. And there's something about narrow versus broad. A chief executive, one of our VCF anchors, said to me a few years ago, if you invest in narrow, you'll get narrow. You'll get beans and widgets, and we'll do it really, really well. But you'll miss all of the other ancillary benefits. Invest in broad, and then you get the full spectrum of the things that my organisation can do. And what he said has stuck with me over many, many, many years. And I think we as a sector have got to kind of think our way through that one systematically and structurally.
Thank you. Joe?
Yeah, I mean, I think the thing I'd add is, I mean, we have in the last 18 months, I guess, had, you know, an experiment in seeing how if there's greater partnership with sort of voluntary and community sector, it does deliver benefits. And, you know, in an emergency, I guess a lot of these things around things like outcome-based commissioning metrics and so on were just put to one side. And, you know, it was really, how can, you know, communities that have very high social capital be best supported to deliver against some of the needs that were in place. And so there's something about not losing what has been learned from that, I think is clearly really important. And then the second thing I think is, you know, thinking in places, you know, it's, you know, yes, you know, we've got to definitely think beyond statutory services. They're important, they have a role, the way they do their role can make a huge difference. We can see how you can have better policing for mental health. We can see how schools have a role. So all the statutory services do, but absolutely, unless we fully harness the assets and the power that sits in communities and also local businesses, you know, again, we saw local businesses step in and play really important roles during the pandemic. So we've got a lot to learn from, and it's about holding on to that and thinking, well, actually, if we can do that in an emergency, how do we sustain those partnerships and that possibility in sort of more normal times?
Thank you. There's a clutch of questions about targets. Do we need targets? Are they necessary to make progress?
I think we did some analysis a few years back, I think, when the industrial strategy set the healthy lives 5 years plus, five greater years of healthy life expectancy. And I think calculated on, you know, current trajectories, it would take something like 70 years to reach that. So I think there is a real challenge around targets. I mean, targets are a good thing for focusing attention, but we've got to be kind of realistic about what progress we're going to see. and therefore make sure we're not just looking at kind of those single high level goals, but actually beneath that, what else needs to be changing to make these improvements possible.
Thank you, Greg.
Just to briefly, I'd agree. I'm wary and mixed views on targets. There's just shades of new public management and all that entails. And the other thing that targets will do is focus our mind on the measurable, which might or might not be the important, because there's a whole bunch of important stuff that just can't be measured. So yes to targets, as long as we invest in actually meeting the ambitious targets we set, but with some caveats around what can't be put into a target.
Thank you. Joanna, do you like targets? Does it help you get out of bed in the morning?
No, but I'm sort of pretty realistic that this is an ambitious government, and I think government want to see that their investment is delivering. So I think we will have targets, but they have to be the right ones and not drive sort of perversity and not induce the sort of bureaucratic response that I think sometimes sort of stultifies policy delivery. So I think it's also important that the government will seek top line measures, but I think it's really important that local places and their partners have the ability to sort of set targets that really do recognise the very specific populations and places that impact them. So a national set of targets, I think, would be unhelpful.
Thank you. There's a big set of questions also from various people about the role of ICSs and the promise of ICSs, integrated care systems, for those of you who aren't in the trade, as it were, and not just, and particularly how they might support primary and community care, given that resources in those areas has been the most constrained over the last 20 years in the NHS. So, so what's the promise, and how could they be supported to do better is the big question, I suppose. Let's start with Greg, because you're closer, I think.
Jennifer, very briefly repeat the question, because you dropped out at a critical moment at the very start.
Oh, sorry. This is about the promise of ICSs
fine.
and how ICSs can help, particularly, particularly in primary. You mentioned primary care and chronic.
So the key thing for me on ICSs is that what are they for? What's the purpose? The purpose will rightly and understandably be about the NHS and constitutional targets. Get that, understand that. That's mighty important to those waiting for a long period. It's mighty important for access to emergency care, etc. But they might miss the point. And one of the points is that sort of the burning platforms of the moment. So social care is with eye-watering financial and service demand risk. Social care is more than adult social care as well. I think we should all do well to remember that social care also includes children. So that's one burning platform, and social care as a totality is burning platform number one. Secondly is primary care. We've said we want the shift from acute to community since my very, very, very first job, more years ago than I'm prepared to admit. We've invested in the opposite. So there's an opportunity for us all to do something different. And the third one is the sort of the left shift. We all want more prevention. Wanless told us it 20 years ago. Carl Claxton told us about the return on investment for public health, kind of narrowly defined, about a year and a half ago. We've not done that. So the challenge and the opportunity for ICSs is to, yes, deliver the things that Parliament will expect it to deliver, rightly and understandably, but to also address the burning platforms.
Thank you. Joanna.
I mean, I feel really lucky to be part of an ICS in Surrey Heartlands where we have got our strategies about improving improving the health of our population. That has been a sort of driver for us. And of course, we recognise all the constitutional targets, but that it's very rare that we are in a meeting together when we don't talk and remind ourselves that 80% of outcomes are driven not by health intervention, clinical health interventions. It's everything else. So our ICS is a slightly wider sort of group of individuals, including people from districts and boroughs. We've got a number of shared posts. We've got a shared Director of Public Service Reform, and their role now will be to take forward this, including how, as the ICS, we respond to the Levelling Up white paper and put some of the economic levers in place as well as all the other things. So I'm hopeful for mine and positive about what we could do together.
Thank you. New opportunity, isn't it, Jo?
Yeah, well, I think I suppose there's several things here. I mean, in the end, what makes for change are relationships and the strength of those relationships and people's commitments to working together, and the kind of structural changes in the NHS. You see them, but I think the places that continue to make the most progress are the ones that have those really strong local relationships. So, I mean, integrated care systems, I think, are kind of signalling something really positive about the need to think more about prevention, and hopefully get more of that investment on the ground. I think the other thing that's really positive that we're seeing at the moment is, of course, how the NHS is really standing back and thinking about the contribution it can make. It may be, one small part of what needs to be done on addressing health inequalities, but we absolutely know there are big inequalities in access to NHS care. There's inequalities in outcomes of NHS care, depending on where you live and your ethnicity and so on. So I think ICS, is if it starts to put a stronger spotlight on some of those factors, that will be excellent. I think more broadly, there's something about how do we pay attention, not just within NHS and social care funding, the investment that goes in prevention, but start looking at all spending across the board and ask ourselves, how much of this is going into keeping people well or keeping people's lives in a good place in the first place, versus how much of it is going on to kind of picking up the pieces and helping people in acute need, and overall need to be looking at how we tip the dial much more to preventative investment across the board.
Thank you. So some questions also here. We've talked about government, national and local. We've talked about the voluntary sector and community groups. And a few of you have mentioned the role of businesses as well. So let's think about the commercial determinants, whether that is the way that businesses can grow the economy locally, jobs, skills, the quality of work, or even the products that they produce locally, and the pollution, I guess. So can you say something, perhaps I'll turn to Joanna first, about what more could local government do, absent any further national action, with businesses to help level up health? Joanna.
I mean, I think we've got to start by sort of recognising that we're all big employers, and the relationships we have with our providers are significant in their role as employers. So I think standing back and understanding how we can support the health and well-being of our own people is a big deal, actually. In our place, we had Philip Hammond running a big growth commission for us to think about sort of our economic position. But the voice of the business community was really loud and stark there about sort of ageing communities, but actually a well population of workers, and an acknowledgement actually that mental health was the biggest issue for them, and they needed to be part of the mechanisms that would think about the allocation of public funding, but their role as well. So, I mean, the reality is, without a healthy workforce, it's difficult to sort of grow an economy. So for me, it is about working with, businesses, local enterprise partnerships, combined authorities, to be clear about, what employers need, and the incentives, I think, that should be there to encourage more employers to invest more in their people, including, there's been some interesting trials, hasn't there, about sort of business rate, reductions, all of that stuff, as a proxy or in return for different investment into health and well-being. So I think you can't do levelling up unless businesses are going to make their workers healthy.
Thank you. And of course, the CBI has a Seize the Moment agenda, which I know Jo's closely close to. So Jo, your comments on this?
Yeah, I think actually probably in the last year and a half, one of the sort of most significant changes I've noticed in some of the discourse around health inequalities is what businesses are saying, and it being something that is much more clearly something they're concerned about. So as you say, the CBI have improving health and reducing health inequalities as one of their 5 goals in their strategy. And I think there's a much bigger appetite on business to stand back and think about sort of what role does it need to play, both in terms of its employment practices, its well-being practices for its workforce, but also thinking about its products and supply chains. I think the other thing at local level is, councils, as in the NHS, there's have big pension funds. There's a big question about where investments are going. Certainly a few years ago, I do remember talking to somebody who worked in the council who told me their pension fund was still investing in tobacco. So I think that's a big agenda. We really need to stand back and ask ourselves whether investments that are being made are aligned with things that we know are good for people's health. And then I guess the other thing where local government has a role is in the licensing and planning. And, it always strikes me that in a town not too far away from me, if I go to the bus station, if I go to the train station, there are no betting outlets. If I go to the bus station, there are 5. And so, there's a question there about what decisions are being made about the environments that we're creating for people to live in, and particularly some of the people who are the poorest in communities.
Very good, thank you. And Greg.
Thanks. So 2 plays on commercial determinants of health. One is the sort of the traditional play on it, which is the work countering what happens in cigarettes, alcohol, gambling, oil and petrochemicals. Climate change was the preeminent public health disaster of the century, probably. So we probably ought to get a grip on that one. There's something about exposing the playbook, because the playbook is pretty much the same. Something about engendering a conversation about the playbook that the companies use to sell their products, and maxing out on the use of local levers and leverage. As Joe has eruditely said, planning pension funds, and there still is tobacco funding in pension funds, advertising what we do and don't allow on advertising hoardings. And there's some difficult choices in all of that. No 2 ways about that. Secondly, on the sort of the work health interplay, to put a lot of energy on small businesses. Most employees are in small businesses, so I think it's helping small businesses see why it matters and why it's important. They've got to own that, and they've got to see that it's something in it for them. And secondly, something about approach. I heard an interesting story about an employer that had invested an awful lot in mental health first aid at work. I heard a story from one of the employees that it was a toxic, bullying work environment. So all the mental health first aid in the world, which is a good thing to do, isn't going to resolve some of the fundamental structural underlying. So both of those things matter.
Thank you so much. Well, amazingly, we're 3 minutes away from a kibosh where we'll all be shut down. So this has gone so fast. I think it's testimony to the fabulous panel that we've had, but also the incredible questions. We've had 111 questions for everybody. So that's where 1 in 4 people have asked a question. So really, really thank you so much. We'll keep a list of those questions. Anyone interested, we'll find a way of putting them somewhere so that you can access them. So thank you very much to our speakers today, Greg, Joe and Joanna. Excellent discussion. Thank you all for taking part. Great questions. Don't forget the recording is going to be online after 24 hours. And just a bit of shameless advertising, our next webinar is on the 12th of October, and we'll be partnering with King's Fund colleagues, examining the future role of public health, lessons from managing COVID-19 a year like no other, based on a publication that's just come out, which is really good, so have a look at that. So that's the 12th of October, more information in our chat and on our website. And on the 2nd of November, we're giving a lecture, well actually Hilary Cottam is giving a lecture on radical change in social care. It's going to be a total treat, that, so please sign up. Again, more info on our website. So meantime, let's wish the national government good luck with its Levelling Up Strategy white paper and the wider cross-government work that it wants to do on health, and the Office for Health for OHID, and also to local government as it tries to help itself by developing better strategies for health inequalities and working with local communities in a trusting way. So many, many thanks indeed, and see you next time. Thank you, everybody. Bye.
Thanks, Jennifer.